Hello and welcome. I'm delighted to have this opportunity to share with you our experience responding to the common clinical and organisational challenges implementing person-centred practice. I'm Caroline Bills from HealthChange Associates, and while much of the workforce development and implementation work is often done by large organisations, HealthChange Associates is a niche private organisation also working in this space to improve how the healthcare system functions. We're all aware of the gap that exists between our intentions and the reality of person-centred practice, and how to get across that chasm is really not clear simply because person-centred practice has many layers and is inherently variable and complex. However, if there was faster adoption and consistency at the point of care, we know that the flow-on effects are likely to be profound. So why is adoption at the coalface so slow? Well, really, we know that clinicians struggle with really truly understanding what those terms mean, and they often don't have a clear guiding implementation system to help them answer these questions. These are the common questions that clinicians often ask us in training, and so we've clearly got a capability issue. Also, such a complex task requires consistent support over time, and with no effective feedback loop, it's easy to see why clinicians might just be tempted to just stay practicing in the way they've been used to. So similar issues exist at the team level of interactions. While there's certainly opportunities for training and professional development, they may not necessarily be specific to person-centred practice, and line managers are often struggling to really have the expertise to translate skills into practice, and they're not experts in behaviour change or implementation science. The other challenge is they often don't have any simple measures of workforce competencies to be able to get any feedback as to whether their training dollar spend is being effective. So again, the complexity of the task, combined certainly with the competing priorities of constant staff changes and very little funding for implementation activities, means that they naturally probably run out of puff. So HealthChange Associates started in this space as trainers in 2006, and we created a course for health professionals focusing on the micro skills, and it looked a little bit like a university textbook kind of theory course at that time. And after numerous years and decades in this space, we really made a lot of iterative changes, integrating feedback that we got from the people who attended our training and from the managers that we were working with that were struggling to answer those questions we just highlighted. And this really transitioned our courses from that textbook theory focus and micro skills focus to a robust clinical practice change methodology. And our partnerships with hundreds of organisations over a couple of countries, and both large and small, and working with research teams, have really tested the tools that we've developed and have enabled teams and programs to translate clinical guidelines into models of care and guide the creation of consistent and scalable intervention protocols. Interestingly, few changes have been needed to the core elements in the methodology since around 2013, which tends to lead us to conclude that we seem to have a practical solution that meets end users' needs. So how is this training different to the other great work that's being done in this space? Well, this graphic shows you the integrated suite of tools that was developed in response to those clinician and manager challenges. And I'll expand on a few of these in a minute. The behaviour change pathway and the BEST framework really provide a common understanding of the order of people's needs if they're going to do anything different. And the methodology also really gives tools for health professionals that really clearly articulate the person-centered practice principles and the essential behaviour change techniques that sit behind the workforce's capability to actually carry out the tasks involved in person-centered practice. And what's quite unique about our methodology is that we also developed a consultation framework and a simple documentation called the Personal Self-Management Plan to provide a guide to order the communication and the skills with the clinical tasks and provide a way to summarise conversations at any point of the care. And these tools can be used by both frontline workers and apply to the communication tools that would be needed to create a person-centred culture for conversations between staff members. And because it's easy to forget quite a lot of this information, we provide a very handy desktop guide. I'll share how some of the tools outline how they really simplify complexity and assist uptake of implementation of these concepts into practice. So after performing a literature review, we created this simple graphic that really shows the order of people's needs if they're going to take action. And we created the concept of the decision line that you can see between the green and the purple. And this separates the processes into above the line, where the focus is on knowledge sharing and exploration of motivation and the big picture decision making, and to below the line processes where the focus of the conversation is much more on short-term actions. So the benefit of this graphic is that it immediately provides a way to apply that concept that many people might be familiar with of meeting people where they're at. And this creates a whole lot of aha moments in health professionals' heads where they perhaps realise, oh, I realise why it's not working because I'm working below the line in the green. That's where my conversation's focused. But in fact, when I think about it, I can see that the patient might be stuck more above the line. And this awareness about their communication style and their comfort level of when they reflect on, well, do I know how to have above the line conversation? What does that sound like in my role? Really leads to a lot of tailored and co-created and team conversations that really sets clear expectations and increases awareness. A common challenge for consumers that we hear is the difficulty of getting the right information at the right time in their point of care for their healthcare journey. And so we created this practical health literacy definition to help teams translate clinical guidelines into a language that both people and clinicians can understand simply. Our definition not only prioritises clinical information, but really highlights that clinicians and healthcare workers have really got to also consider, well, what's the information that the consumer needs right now at this point in their care? This creates really rich jumping off point for team discussions and to co-create their particular messages and layer the information that they deliver to the consumer. And it also creates awareness of where there might be misalignment or gaps in either the health provider's knowledge. A game changer for accelerating uptake of the concepts of person-centered practice into practice was the articulation of the person-centered practice principles and the essential behaviour change techniques that sit behind the ability to do these work with these principles in an interaction. Clinicians really wanted simple labels, and they find that now they can leave our training with a clear understanding that if they are not feeling competent at flexibly using all of these principles, then they're not perhaps quite as person-centered as they thought. These labels can then really be used as workforce competencies, again with very simple labels that both clinical and non-clinical staff will relate to. And as I said before, they relate to all levels of communication across the organisation. So when you create these quite clear but simple behavioural and process definitions, it enables you to much more easily start to target your workforce development and skills support activities or quality activities within your organisation. And then you can track what you've been doing and embed reflective practice activities and discussions within the team that are targeted to that particular health context. And certainly you can then also combine these with self-reflection tools to track the team's competencies to actually perform these tasks. As many of you would appreciate, evaluating the impact of what we do as a niche training organisation is quite challenging, because either that is only one factor amongst many influencing a service's outcomes. We've worked with numerous organisations over time, and here's a list of the publicly available reports or trials from organisations that we've actually had quite significant relationships with, and numerous of these programs report improvements to patient experience as well as clinical outcomes. There have been some specific trials that have investigated the impact of HealthChange methodology training, and they have certainly demonstrated changes to clinician beliefs and attitudes, and concluded that the training had a positive impact on practice. In one osteoarthritis program, HealthChange training was recently identified as a key facilitator to actually implementing the program, and our colleagues in Alberta have recently gathered data from 342 providers, of which 92% agreed that HealthChange methodology enabled more person-centred care. So are we there yet? Well, no, of course not. There's a lot more work to be done. However, we believe that the components that are contained in HealthChange methodology seem to support the fact that if you use these tools, that they do flow on to better experience for consumers, for the workforce, and for the health system more broadly, and do appear to align with the characteristics that experts in the implementation and the education field are calling for. So I'd encourage you to consider that, and if you'd like to access any of those papers, use the QR code here. Thank you very much for listening, and I hope we can connect.